Audio recording. So today's lecture is on bleeding and clotting disorders. So we'll be starting with these disorders which are commonly seen in childhood, and uh, we'll start with begin. There are four major problems which we see come across in children are ITP, that is immune thrombocytopenia, DIC, that is disseminated intravascular coagulation, aplastic anemia, and hemophilia. These are the common ones which are seen. These are the common bleeding and clotting disorders. We'll start with ITP, also called as immune thrombocytopenia. It is an autoimmune disorder, commonest bleeding disorder seen in children, and the common age group affected is 1 to 7 years. Chronic ITP is common in girls. It is characterized by petechial hemorrhages, ecchymosis, which are commonly seen, decreased platelets due to their destruction by the presence of platelet antibodies, and this leads to increase in megakaryocytes in the bone marrow, which is classical for ITP. It is also called as idiopathic thrombocytopenic purpura. These antibody-coated platelets, which are trapped by macrophages of the reticuloendothelial system, that is the spleen, and are destroyed over there. Thrombocytopenia, if it is less than 6 months occurring, then it's called as acute, while if it persists more than 6 months, it is called chronic ITP. Clinical features: febrile illness is in the past, that is recent history of fever, cold, cough in the recent past is a classical history. Sudden bruising, mucosal bleeds, petechiae all over the body, no splenomegaly, no lymphadenopathy. Platelets are decreased. Usually, we see patients coming with platelets down less than 20,000. Treatment of ITP is IVIG 1 gram per kg per day. Steroids after doing bone marrow to rule out if any malignancy is there or not. Splenectomy, if the patient is going into chronic ITP and not responding to the treatment, then we can do splenectomy. And platelet transfusions are given only if the platelet count is going below 10,000, is, or if the patient is profusely bleeding due to thrombocytopenia, or if the patient is going for surgery, then we give platelet transfusion. Steroids are also one of the part of treatment. Hemophilia, it is the commonest clotting disorder. Also, it is an X-linked recessive disorder. Males are affected as it is an X-linked recessive disorder. Hemophilia A, classical one is due to factor A deficiency. Hemophilia B is due to deficiency of factor 9. Deficiency leads to spontaneous bleeding or after trauma or surgery. Prevalence of hemophilia is 1 in 10,000 males. 85% of hemophilia are hemophilia A. Three types are present, three varieties are of hemophilia there, that is mild, moderate, severe, according to the grades. If the mild variety, usually the child presents first time more than 2 years of age, and factor VIII activity is more than 5%. Moderate hemophilia is said when the patient has presented below the age of 2 years, and factor VIII activity is between 1 to 5%, while severe one presents below the age of 1 year in the first year of life only, in which the factor activity is less than 1%. Common sites of bleeding in hemophilia are joints. They huge, large joints. They are painful and they are called as hemarthrosis. A patient may bleed inside the muscles or tissues. CNS bleeds will give CNS manifestations in the form of seizures, coma, and all that, and neurodeficits. GI bleeds are also found. Neck and throat bleeds, bleeding from trauma site and surgical sites. Yes, the PT is normal in hemophilia because it is the intrinsic pathway which is affected. Factor VIII is in the intrinsic pathway. So APTT is prolonged. Platelet counts are normal. Then the BT, that is bleeding time, is normal, while clotting time is increased because of factor VIII deficiency. And if we do factor VIII assays, we find that there is factor VIII deficiency. The treatment of hemophilia is factor VIII concentrates 15 units per kg. We can also give fresh frozen plasma, cryoprecipitates, epsilon amino caproic acid or tranexamic acid to stop the bleeding. Hepatitis B vaccination should be done in all the cases of hemophilia because they are going to receive blood transfusions off and on. And injury counseling is a must thing. Which sports to be played, which not to be played, we have to counsel the parents and the patients accordingly. The third variety of bleeding and clotting disorder is disseminated intravascular coagulation or dysregulation of hemostasis. Activation of clotting cascade leading to bleeding and fibrin deposits in the microcirculation is the classical thing. Platelet and clotting factors are consumed in this case. Platelets, and therefore the platelets go down. PT, APTT, and TT, all the three time are prolonged, and fibrinogen levels also go down. Causes of DIC are severe sepsis, injury, snake bite, surgeries, that is, surgeries longing for more time, tumors or massive tumors or large tumors, etc. The patient is bleeding profusely from different sides, and obviously the patient is going in shock. And that is the picture. He's bleeding from nose, bleeding from GI tract, he's bleeding from, there's a blood in urine also, there's hematemesis, ecchymotic patches, and so the patient is bleeding from all sides, so the chances of going into shock are very high. The treatment includes IV fluids, resuscitation of the patient. Vitamin K is the vital thing to be given, oxygen, fresh frozen plasma, platelet concentrates, antibiotics to avoid sepsis or to treat secondary sepsis. And the shock management is, of course, very important. And the treatment of the cause of sepsis is very important. For example, if the patient is having history of snake bite, we have to give anti-snake venom. So this is the management in general of DIC. Aplastic anemia, the name itself suggests that there is aplasia of the bone marrow leading to severe anemia. All the three cell line series are involved in this. It is a disorder of hemopoietic stem cells, usually involves the three cell lines. Aplastic anemia can be congenital or acquired. It is also known as bone marrow failure. Etiopathogenesis of aplastic anemia, congenital and acquired. In congenital variety, mutations in the genes may occur leading to hemopoietic stem cell, means there is a dysregulation in that, and therefore all the three cell line series are affected, resulting in bone marrow failure. The second one is acquired stem cell injury, which is most common and is most commonly due to viruses like parvovirus B19 infection, hepatitis B virus, hepatitis C virus, cytomegalovirus, Epstein-Barr virus. These are the viruses leading to bone marrow depression. And the other ones are toxins, chemicals, and drugs. The most common drug known to cause decreased bone marrow functioning is chloramphenicol. Even anti-malignant drugs, NSAIDs, these are all said, even anti-malarials are said to cause bone marrow failure or decrease in the functioning of the bone marrow, leading to aplastic anemia. And therefore the history, whenever we ask the history in a case of aplastic anemia, we have to ask history of various drugs, history of viruses, viral infections, chemicals, toxins, etc. Abnormal cellular control of the hematopoiesis also may lead to bone marrow failure. Clinical features are classical because of all the three cell line series are affected. So if there's decrease in RBC production, that will lead to severe anemia, leading to congestive cardiac failure. Second, when the WBC count is going low, called as leukopenia, that will lead to fever, that will lead to secondary infections, that will lead to pneumonia, meningitis, sepsis, etc. And the third one is the platelet counts. When they are going down, patient is bleeding from different sides, leading to GI bleeds, hematemesis, nasal bleeds, gum bleeds, petechiae, ecchymosis, etc. The investigations to be done in this case are complete blood count. The peripheral smear will itself show that there is pancytopenia, leading to neutropenia, anemia, thrombocytopenia. Retic count is classically low because the bone marrow itself is not functioning, so the precursors of the RBCs are not seen, and therefore retic count is decreased. Bone marrow biopsy is the ultimate answer to give the cause and to confirm the aplastic anemia. When the aplastic anemia is confirmed, the treatment, of course, is the general management of the patient, which leads to general care of the patient. We have to counsel the patient regarding different sports activities so that he should not get trauma and he should not bleed from different sides. He should do brushing with soft brush bristles. Then his groin, axilla, and all the folds should be taken care of so that there will not be any infection. That is the site of infection. Patient should have soft diet, a well cooked diet. He should avoid raw diet. Then secondly, the management includes antibiotics, because patient is always there's a fear of him landing into infections. And so first we should start with the preliminary first line drugs like penicillin group of drugs along with aminoglycosides, or upgrade them if the fever is not settling to third generation cephalosporins for the next 3-4 days. If the patient still doesn't respond to fever, then we can go on to MRSA like vancomycin group of drugs, or to imipenem's group of drugs. We can add on with antifungal if the fever is not settling down, or if we are suspecting some fungal infection. Then the blood transfusions, we have to give packed red cells, multiple packed red cell transfusion, platelet transfusion to avoid bleeds, and for to increase the WBC count, we have to give fresh frozen plasmas till the patient starts responding, and till the infection rate goes down. But the ultimate answer for plastic anemia is bone marrow transplant, that is stem cell transplant is the ultimate answer for a plastic anemia. So this is regarding bleeding and clotting disorders. The bleeding disorders, these actually include thrombocytopenia. As I've told, there are many other causes of thrombocytopenia, but we also have to rule out infections like dengue fever, malaria, which also leads to thrombocytopenia. Investigate the patient accordingly and treat them. One common cause of bleeding disorder or bleeding time increased is even scurvy infections may lead to bleeding from different sites, and also we have to rule out that, or any vasculopathy or vasculitis may also have fragile vessels leading to bleeding. So these are all the bleeding disorders which we have to rule out, and also then we have to come to whether it is a clotting disorder or a bleeding disorder if the patient is uh, bleeding from different sides. Thank you very much. अरे ध्रुव, ध्रुव